Welcome to this Step 3 clinical knowledge review on acute coronary syndrome management test-taking strategies, brought to you by Roadmap to Residency. Heart attack questions look intimidating, but they reward a calm, ordered approach far more than raw memorization. Today we will break down how the boards build these stems and how to choose the right next step quickly and confidently. Our goal is not to reteach all of cardiology. It is to train your eye to spot the pattern and apply a rule. Before or alongside this video, review the cardiology section of your major review books and a strong question bank so the foundation is already there. Let us get started. Here is our plan for the next several minutes. First, we will recognize the high-yield chest pain stems and the electrocardiogram findings that change everything. Second, we will work the ST elevation heart attack, where the clock and the door-to-balloon time decide the answer. Third, we will handle the non-ST elevation heart attack, where risk stratification tells you whether catheterization is urgent or can wait. And finally, we will lock in the discharge medications that examiners love to test, including dual antiplatelet therapy, statins, and beta blockers. Remember, this video is about strategy. Use your major review books and your question bank for the deep foundational content, and use this session to learn how to apply it under pressure on exam day. Strategy 1 is the single most important reflex for these questions. Let the electrocardiogram sort the patient before you do anything else. If you see ST segment elevation in 2 neighboring leads, or a new left bundle branch block, you are in the time-sensitive lane. The question is testing immediate reperfusion, and any answer that adds delay is wrong. Do not order one more test when the tracing has already made the diagnosis. On the other side, if the tracing shows ST depression, T-wave inversion, or looks normal, you are in the non-ST elevation lane. Here the troponin and a risk score decide your timing. The classic trap is rushing this patient straight to the catheterization lab when the STEM actually wants you to stabilize, start the medicines, and stratify the risk first. One glance at the tracing tells you which set of rules applies. Strategy 2 is all about the clock. For an ST elevation heart attack, the whole question often hinges on where the patient is and how fast you can open the artery. If the hospital can perform percutaneous coronary intervention, your target is a door-to-balloon time of 90 minutes or less, and the answer is to activate the catheterization lab immediately. Look for the choice that takes them straight to the artery and reject anything that adds repeat imaging or observation. But if the patient is at a center that cannot perform the procedure and getting them to one would take more than 2 hours, then clot-dissolving therapy is the answer, as long as the stem gives you no bleeding contraindication. The single board rule that ties this together is to open the artery the fastest, safe way. Read the stem for the location and the time, and those 2 facts choose the balloon or the medicine for you. Let us train pattern recognition on the 3 stems you will see again and again. First, the ST elevation stem. Crushing chest pain with ST segment elevation in the inferior or anterior leads means open the artery now. If a catheterization lab is available, activate it for primary percutaneous coronary intervention. The winning word here is immediate, never observation. Second, the non-ST elevation stem. Chest pain with ST depression or a rising troponin, but no ST elevation, means stabilize with medicines first, then use a risk score to decide timing. High-risk features push catheterization within 24 to 48 hours, not the next minute. Third, the discharge medication stem. A stable patient after a stent, asking what to send them home on. The reflex bundle is dual antiplatelet therapy, a high-intensity statin, a beta blocker, and an agent that blocks the renin-angiotensin system. Leaving one of those out is exactly how the examiners trap you. Here is our first practice question. A 58-year-old man arrives with 1 hour of crushing substernal chest pain radiating to his jaw. He is diaphoretic. The electrocardiogram shows 2 millimeters of ST segment elevation in the inferior leads. This hospital has a catheterization lab that is ready. What is the most appropriate next step? Read the choices. Choice A, a computed tomography angiogram of the chest. Choice B, activate the catheterization lab for primary percutaneous coronary intervention. Choice C, give clot-dissolving therapy and admit for observation. Choice D, wait for the troponin result before acting. Take a moment to commit to your answer and notice which clues in the stem are doing the work. We will walk through it together on the next slide. Let us walk it through in 3 steps. Step 1, spot it. Crushing chest pain plus ST segment elevation in contiguous inferior leads is an ST elevation heart attack until proven otherwise. The tracing has already made the diagnosis, and the dominant signal here is time, because heart muscle dies every minute the artery stays blocked. Step 2. Apply the rule. When a catheterization lab is available, the answer is primary percutaneous coronary intervention, with a door-to-balloon time of 90 minutes or less. That is, choice B, you open the artery directly, the fastest and safest way at this hospital. Step 3. Eliminate. Choice A delays care for an unhelpful scan. Choice C reaches for clot-dissolving medicine when the superior balloon option is right here in the building. Choice D waits on a troponin you simply do not need because the tracing is already diagnostic. The answer is choice B. Here is our second practice question, and it lives in the non-ST elevation lane. A 64-year-old woman has 2 hours of chest pressure. The electrocardiogram shows 1 millimeter of ST segment depression in several leads. The first troponin is elevated and rising, her blood pressure and heart rate are stable, and her chest pain eases with initial medical therapy. What is the most appropriate next step in management? Choice A, immediate clot dissolving therapy. Choice B, start medical therapy and plan an early invasive catheterization within 24 to 48 hours. Choice C, discharge home with outpatient stress testing next week. Choice D, emergency surgery for coronary bypass tonight. Pause and pick your answer, and pay attention to 2 facts in this stem. There is no ST elevation, but the troponin is rising. Those 2 together set up the whole question. Let us work the second question. Read it carefully first. Chest pressure, ST segment depression, and a rising troponin with no ST elevation is a non-ST elevation heart attack. She is stable and improving with medicine, and there is no ST elevation that would trigger the immediate balloon or the clot-dissolving pathway. Now, why does early invasive win? A rising troponin is a high-risk feature, and high-risk non-ST elevation patients earn an early invasive strategy. That means catheterization within 24 to 48 hours after medical therapy is started. That measured timing is choice B. Finally, eliminate the rest. Choice A is wrong because clot-dissolving therapy has no role at all without ST elevation. Choice C undertreats a rising troponin and is genuinely unsafe. Choice D leaps to surgery before anyone even knows the coronary anatomy. The answer is choice B. Notice how the absence of ST elevation plus a high-risk feature pointed you to timing, not to a rushed procedure. Once the artery is open, the questions shift to aftercare and discharge. On the left, care right after the procedure. The exam rewards careful monitoring for bleeding at the access site, watching the kidney function after the contrast dye, and checking the heart rhythm. You also continue the dual antiplatelet therapy that keeps the new stent open. The guiding principle is to protect the freshly opened artery and to catch complications early. On the right, the discharge medication bundle, and this is pure points if you memorize it. Send the patient home on dual antiplatelet therapy, meaning aspirin plus a second agent, a high-intensity statin, a beta blocker, and an agent that blocks the renin-angiotensin system. Each one lowers future risk in a way the others cannot. The classic trap answer quietly drops a single member of this bundle, so always check that all 4 pieces are present. Our third practice question is the discharge medication classic. A 60-year-old man is 2 days past a stent placed for a heart attack. He is now stable, walking, and pain-free, with a blood pressure of 130/80. The team is writing discharge orders. Which medication regimen is most appropriate to send him home on? Choice A, aspirin alone. Choice B, aspirin, a second antiplatelet agent, a high-intensity statin, and a beta blocker. Choice C, a beta blocker and a statin only. Choice D, a second antiplatelet agent alone with no aspirin. Pause and choose. The key is to remember the full bundle and to notice which options are missing a critical piece. Let us break it down. Let us finish the discharge question. First, recall the bundle. After a stent for a heart attack, the standard discharge set is dual antiplatelet therapy, which is aspirin plus a second agent, together with a high-intensity statin and a beta blocker, and usually an agent that blocks the renin-angiotensin system as well. Second, match the answer. Choice B is the only option that keeps both antiplatelet agents alongside the statin and the beta blocker. It reflects the complete evidence-based bundle that lowers the chance of another event, which makes it correct. Third, eliminate the rest. Choice A drops the second antiplatelet agent that the fresh stent depends on. Choice C omits antiplatelet therapy entirely. Choice D removes the aspirin and breaks the dual therapy. Every missing piece raises the patient's risk. The answer is choice B. When you see a discharge stem, count the bundle on your fingers and pick the option that has every member. Here is the pearl that ties everything together. Think in 2 lanes and decide the lane with one glance at the electrocardiogram. ST elevation means open the artery now. Use the balloon if a catheterization lab is ready, and use clot-dissolving medicine if transfer would be too slow and there is no bleeding risk. No ST elevation means stabilize the patient. Start the medicines and let the troponin and the risk features set your timing. Sort the lane first, and the management answer follows almost on its own. Why does this win points? Because the exam tests 2 reflexes over and over. First, the electrocardiogram chooses the pathway before any other test you might order. Second, for every stented patient, the discharge bundle of dual antiplatelet therapy, a statin, and a beta blocker is your safe default. Recognize the lane and remember the bundle, and these questions become some of the fastest points on the exam. That brings us to our final tips and where to learn more. For your study plan, review the cardiology chapters in your major review books and your question bank. Focus on the electrocardiogram pathways, the door-to-balloon target, the timing of catheterization for non-ST elevation cases, and the full discharge medication bundle. Master those 4 areas, and you will handle almost any acute coronary syndrome question the exam throws at you. And before you go, connect with us. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized plan. If this video helped you, please like and subscribe so more students can find it, and so you never miss our next board review session. Thank you so much for studying with us, and good luck on your exam. You have got this.